I am very excited to introduce Dr. Conran, a biochemist training at the University of Birmingham, the other Birmingham, I think, and the University of Nottingham in the UK, and has been based in the University of the Campinas in Sao Paulo, Brazil, for over 20 years. And she investigates our favorite subject, the pathophysiology of sickle cell disease. And I'm excited because a lot of her work is focused on inflammation and vascular abnormalities, which I think are prominent and get worse as people age, that are associated with sickle cell disease and how these contribute to hemolysis and the inflammatory processes. And so I am really excited to introduce you and want you to take it away from here. Thanks for joining us.
Yeah, thanks very much for that introduction. I'm really pleased to be here today. So, you know, I've got all of your work at the center, so thanks for inviting me. Okay, so I'm just going to share my screen. Can you see that?
Yeah, it's not presenter mode, but that's
yeah.
okay.
Yeah. There we are. Is that it?
Perfect.
Yeah. Okay. So obviously, I'm going to be talking to you about inflammation as a driver of sickle cell disease, pathophysiology today. So I'm from Campinas, which is in the state of Sao Paulo in Brazil. And I can't actually see anyone from the mode that I'm using at the moment. So if you need to interrupt me, just say hi or something. So that's fine. So why do we need to understand the role of inflammatory pathways in sickle cell disease? Julie was saying that I've been working in sickle cell disease for over 20 years now. And at the time that I started working, the research in our center, like much of the research at the time, was focused on the mechanical problems of sickle cell disease. But it was becoming very clear that due to the persistent multi-organ problems that we were seeing in the patients, that we were missing something. So we and others have established, with a lot of very, very good researchers who have been working on inflammation in sickle cell disease, we see now that that sickle cell disease is driven by an established, it's fundamentally a vascular inflammatory disease. And we see that this vascular inflammation is driven by continuous blood cell inflammation, blood cell activation, which happens not just during crises, but all the time. We realize it's very obvious that there's a pathological cycle that we now target, and the problem begins with our abnormal sickled red blood cells in the vasculature, which will contribute to triggering vasocclusion. And then this vasocclusion will immediately induce inflammation in the vasculature. So this generates inflammatory molecules and cellular activation in the location, which is going to then further propagate these vaso-occlusive processes. And so in turn, both the continuous vasocclusion and this persistent inflammation will end up triggering and causing severe organ damage, which is something that we're all very interested in preventing nowadays. So when I was putting this talk together last week, I realized that I never actually talk about what inflammation is. And it's probably quite important to introduce this because there are certain aspects of inflammation that are important to the pathophysiology of sickle cell disease and aspects that are important to remember. So inflammation can basically be broken down into sterile inflammation and into non-sterile inflammation. Sterile inflammation is basically an endogenous response to either tissue or cell injury, and it's not caused by pathogens. I mean, that's the very important point about sterile inflammation. It's driven by host-derived molecules, which are called DAMPs, and important DAMPs that we see in sickle cell disease are cell-free heme, as well as other DAMPs such as extracellular ATP, HMGB1, heat and heat shock proteins. So basically, sterile sickle cell disease is the body recognizing its own internal stress signals. And then on the right, we see non-sterile inflammation. And this is the classic immune response that's driven by PAMs, or pathogen-associated pathogens that are derived from bacteria, such as lipopolysaccharide from bacteria, and viral PAMs, such as viral DNA and double-stranded RNA. So regardless of whether our inflammatory sugar is a PAMP or a DAMP, both of these pathways converge on our innate immune cells, particularly the neutrophils and the monocytes, and signaling of inflammation often occurs through signaling complexes such as the inflammasome. So this initial state is going to result in triggering acute inflammation, and this is characterized by clearing mechanisms such as phagocytosis, the production of NETs, mainly from neutrophils, and also the generation of reactive nitrogen or oxygen species. And if this stimulus isn't cleared, we're going to progress towards a chronic inflammation, continuous inflammation in which we see the recruitment and activation of other cells such as the lymphocytes. And this is the situation that we see in sickle cell disease, a chronic inflammatory state which happens continuously during the patient's life. The idea during inflammation is that we get resolution of inflammation. So ultimately, a successful response to inflammation will culminate in resolution of inflammation. And this is a phase where pro-resolving mediators initiate the vital process of erythrocytosis, which is the cleaning up of dead cells. And also we get wound healing to restore the tissue to its homeostatic state. In fact, in sickle cell disease, we never actually generally reach this situation of the resolution of inflammation because we're in this chronic inflammatory state in these patients. So I think you're all very familiar with this diagram about the complications of sickle cell disease, but it's really important to remember that actually inflammation is key and a major contributor to many of these complications of sickle cell disease. So basically, the complications of sickle cell disease can be categorized as acute or chronic. In the acute complications, obviously we have the painful vaso-occlusive episodes, which are characteristic of sickle cell disease. And as we'll see, it is inflammation that drives and propagates these processes. And then there's also we have these acute life-threatening events such as stroke and acute chest syndrome, to which inflammation plays a really important role. Then the real burden of the disease really does come from chronic complications which stem from persistent inflammation and also organ damage. We see neurocognitive degeneration in patients as well as pulmonary hypertension, issues in the liver and the kidneys, such as hepatic complications and kidney disease. We also see retinopathy in the eyes and avascular necrosis with the destruction of bone tissue in the joints. So chronic inflammation and the occlusion of blood vessels will lead to continuous systemic damage, and really we need to understand how these inflammatory processes occur to enable us to manage this painful and multi-organ disease. So this is a very classic diagram of the vaso-occlusive process, which was drawn by Lidiane Torres, who has been in the Einstein College of Medicine until recently, but she did do a postdoc in our lab. But basically, you see that inflammation is caused and driven as well as propagated by this inflammatory state. So we have a generation of numerous inflammatory molecules in the blood vessel, and this is going to lead to pancellular activation in the blood vessel. With this pancellular activation, we're going to have the expression of adhesion molecules on the endothelium and also on the surface of leukocytes, platelets, and red blood cells, as well as other cells in the vasculature. This cellular adhesion is going to end up reducing the blood flow in the blood vessel. This is because the cells adhere to the endothelium and also form heterocellular aggregates between the cells. And when we get this reduction in the blood flow due to this agglomeration of cells in the blood vessel, we're going to end up reducing cellular oxygenation, and we're going to increase the thickning of red cells in the vasculature. These red cells become trapped in these agglomerations of cells, and we will see the reduction of blood flow, and eventually this can lead to vaso-occlusion, especially in small caliber blood vessels. So this is just a slide to highlight how we can study the vaso-occlusive process. In our lab, we use intravital microscopy, and we use this to study vaso-occlusive processes in mice with sickle cell disease and in mice without sickle cell disease. So here on the left, we see the venule of a mouse with sickle cell disease that has not been subjected to any kind of inflammatory stimulation. And on the right, we see the venule of a mouse that has received an administration of TNF-alpha, which is a very potent inflammatory cytokine. So in the mouse that didn't receive any kind of stimulation, even though it's a sickle cell mouse, we do see a very fast blood flow in this venule, and the flow seems to be going on quite happily here. Whereas in this mouse that's received the TNF-alpha administration, we see that there's rolling of leukocytes along the endothelial wall, and also firm adhesion of these leukocytes. And this ends up causing some kind of obstruction in the blood flow, causing sickling of the red cells, and eventually vaso-occlusion. Although vaso-occlusive processes are constantly occurring in sickle cell disease, if there's an inflammatory stimulus around, this is going to be inducing overt vaso-occlusive processes. So we see here that the leukocytes roll along and adhere to the endothelium of the cell wall, and this alters the hemodynamics of the vessel and triggering red cell sickling, as we saw. And the primary role of this adhesion of the leukocytes, particularly the neutrophils to the blood vessel wall, was first proposed by Frenette's group over 20 years ago. And so these, as I mentioned, these kinds of models are frequently used to understand how this vascular inflammation occurs. So there are actually functional consequences of these inflammatory processes that we saw, and vaso-occlusion can reduce both the blood flow and perfusion to tissues, and we use techniques such as laser flowmetry and laser speckle contrast imaging to look at these blood flow tissues. So at the top here, we see the blood flow velocity and the blood flow perfusion percentage in the skin of unstimulated mice in orange. And then you see in blue that blood flow velocity and blood perfusion in mice that have received a TNF-alpha stimulus to induce inflammation and vaso-occlusion, as we saw before. And these vaso-occlusive processes reduce blood flow velocity significantly, and they also very significantly reduce the perfusion of blood in tissues such as skin, in this case, that we can see using laser flowmetry. And then we see here at the bottom this imaging from laser speckle contrast imaging. This visually confirms the effect of vaso-occlusion in real time. So on the left, you see the ventral side of a mouse with sickle cell disease that hasn't received any kind of inflammatory stimulus. You see a fairly good blood flow in this animal, as you can see in red. However, when an animal receives a TNF inflammatory stimulus, we can see a slowdown of this perfusion and cooler areas in blue and green in the body of this mouse, this can also be quantified here to look at how this perfusion is reduced. So these inflammatory processes and vaso-occlusion will cause hyperperfusion, which will contribute to pain in patients as well as tissue damage. So I've mentioned how vaso-occlusion is important in sickle cell disease, and we need to understand how inflammatory processes also take, as well as vaso-occlusion, contribute to tissue injury in sickle cell disease as well. So we see how inflammation contributes to vaso-occlusion, and now we also need to understand how inflammation contributes to tissue injury. We can study organ lesion in mice with sickle cell disease. For example, at 22 weeks of age, mice with sickle cell disease demonstrate extensive hepatopathy compared to control mice. So this is the liver of a sickle cell disease mice and the liver of a mouse without sickle cell disease. At this age, these mice, in this case, this is a Berkeley mouse. These mice display vascular and sinusoidal congestion in their livers, They also display intralobular necrosis, and there are periventral fibrotic bands in the livers of mice with sickle cell disease. This sinusoidal congestion and collagen deposition can also be seen using confocal microscopy in the livers of these mice. So we recently published a study in which we wanted to see how different immunotherapy strategies could affect both vaso-occlusive processes and also affect organ damage and organ health in mice with sickle cell disease. So this is the first part of the study where we're just looking at the acute effects of these immunotherapies and looking at vaso-occlusive processes. So here we see that we blocked P-selectin here in red with an anti-P-selectin antibody, and we looked at the perfusion, blood perfusion in skin, and we also looked at the recruitment of leukocytes in the venules of these mice with a TNF-alpha cytokine stimulus and without a TNF cytokine stimulus. So you see in mice with sickle cell disease, as soon as you give TNF-alpha, this is going to reduce the blood perfusion in these mice and also increases leukocyte recruitment in the venules. However, if you give anti-P-selectin just before inducing this vaso-occlusion, you can completely reverse the effect of TNF on the increased blood perfusion in the skin, and you can also diminish very considerably the recruitment of leukocytes through the blood vessel wall. So blocking P-selectin can inhibit TNF-induced vaso-occlusion in sickle cell disease mice. At the same time, we also looked at how blocking interleukin-1 beta with antibodies can affect vaso-occlusion. And you can see here that actually when you block interleukin-1 beta, you end up having a very similar effect to what we see with TNF with blocking P-selectin. You can see that blocking interleukin-1 beta inhibits the effect of TNF-alpha on reducing blood perfusion and also significantly reduces the recruitment of leukocytes in the venules after the TNF-alpha stimulus. So both blocking TNF-alpha, blocking both P-selectin and blocking interleukin-1 beta will inhibit TNF-induced vaso-occlusion in mice with sickle cell disease. Although this does seem to happen by slightly different mechanisms. However, the story is a bit different when you give these immunotherapies over time to mice with sickle cell disease. So while both of these immunotherapies acutely were able to block the effect of TNF-alpha on vaso-occlusion, the inhibition of interleukin-1 beta, but not the inhibition of P-selectin with immunotherapies over 6 weeks was able to decrease and improve organ health, particularly in the lungs, reducing the congestion that we see in the liver of these mice and fibrosis in these mice. So you can see that in blue here, where giving anti-interleukin-1 beta for 6 weeks reduced liver congestion and also reduced fibrosis in these mice. Importantly, interleukin-1 beta blockade ameliorated inflammatory processes, and interestingly, we saw a complete abolition of iron accumulation in the liver and also in other organs of the mice with sickle cell disease when they received interleukin-1 beta. And that's important because although the iron accumulation isn't so severe in sickle cell disease, this iron accumulation that does occur in the organs is contributing to oxidative stress and to damage in these organs. So importantly, we see that an aspect of sickle cell disease that's been worrying clinicians and patients is the long-term organ damage dysfunction that occurs in patients as they get older. We know that red cell sickling and continuous vaso-occlusive process will cause hyperperfusion, and this is going to reduce the oxygenation of tissues. And together, these processes will cause the release of inflammatory molecules into the circulation, particularly the cytokines, setting off a cascade of damage, as well as inflammatory infiltration in the organs. And we also see this overwhelming oxidative stress due to iron accumulation, which will also contribute to inflammatory cell infiltration in organs. And over the years, this is eventually going to cause widespread fibrosis and necrosis of vital organs and leading to this organ damage, organ dysfunction that is a characteristic of the disease as patients age. However, what we saw in this study that we published this year is that apparently decreasing vaso-occlusive processes alone doesn't seem, at least in our model of sickle cell disease, this doesn't seem to be sufficient for reducing organ damage. We need to reduce inflammatory processes too, to be able to reduce the progress and to halt the progress of organ damage in sickle cell disease, at least in the mouse model that we've been using. We've been talking about the vaso-occlusive process. We've been talking about the damage that inflammation causes to tissues and to organs, but I want to look a little bit closer at the inflammatory mechanisms that lead to the vaso-occlusion and then to inflammation in general, and to understand the events that lead to vaso-occlusion in sickle cell disease. So I've said a number of times that vaso-occlusive events are triggered by inflammatory events and also propagated by inflammatory processes. So one of the current processes that we have is to try to link how physiological events can trigger molecular mechanisms that cause vaso-occlusion in sickle cell disease. And we're carrying out this project with researchers in collaboration with researchers at the University of LCSCC. And they're doing the in vitro part of the study, and we are working on the in vivo part of the study. So we know that there are a number of physiological events that seem to be associated with the initiation of vaso-occlusive crises in patients. What these include, but aren't restricted to, hypoxia and reperfusion. We also know that dehydration and together with this increased intestinal permeability can cause vaso-occlusive crisis in patients. Hemolytic events can increase vaso-occlusion, as well as cold temperature can trigger vaso-occlusive crisis in some patients. Infections and even psychological stress can cause vaso-occlusive episodes. So we'll be talking about these sources of inflammation a little bit later, but what we've been doing is mapping these physiological events to specific molecular triggers that we can use to try and simulate these events and to see how they cause vaso-occlusion. So what we do is we use sickle cell mice, and we look at whether the inflammatory molecules that we are going to be using differ in the vaso-occlusive mechanisms that they induce. So we've been trying to simulate hypoxia and reperfusion using TNF-alpha cytokine and also interleukin-1 beta as a molecular trigger of vaso-occlusion. As you know, hemine can be used to mimic intravascular hemolysis in sickle cell mice to induce vaso-occlusion and to try and mimic the effects of dehydration and bacterial infection. We have been administering lipopolysaccharide or LPS to mice, which is a bacterial component. To try and simulate a viral infection, we've been using the administration of interferon alpha. So, as you know, at this time, there is no therapeutic approach for reversing vaso-occlusive crisis in a patient once they're hospitalized with an episode. The only thing that you can do is manage the crisis, giving them hydrating the patient and giving them pain medication. And what we all want is to find a way to reverse vaso-occlusion in these patients to shorten the time that they're in hospital. So the idea of this project is to ultimately profile the different mechanisms by which these events can cause vaso-occlusion. And that means that if we can identify differences in the mechanisms according to the trigger of vaso-occlusion that we're using, we may be able to develop a more targeted approach for treating vaso-occlusion according to the events that cause this vaso-occlusion and the vaso-occlusive event. So all of the physiological and molecular triggers that I mentioned before do cause vaso-occlusion in mice with sickle cell disease, but there seem to be very subtle differences in how this vaso-occlusion is orchestrated. So as an example, we've been using the bacterial component LPS to trigger vaso-occlusion in mice with sickle cell disease. And in these mice, you can see using laser Doppler flowmetry again and laser spectral contrast imaging that administering LPS to an animal significantly decreases blood velocity and blood perfusion in the skin of these mice. So that means that LPS does induce significant vaso-occlusion in these mice. However, our data show that there is a very significant production of inflammatory molecules in these mice once they've received this LPS stimulus. And we do see a role of this leukocyte recruitment in this vaso-occlusive process. But interestingly, we see a small increase in the rolling of leukocytes along the blood vessel wall, but what we do see is a very, very significant increase in the adhesion of leukocytes to the blood vessel wall, the firm adhesion. So leukocytes, they need to roll along the blood vessel wall to firmly adhere afterwards. And this is a little bit different to what we see with some of the other molecular triggers of vaso-occlusion. We see both the increase of both rolling and of leukocytes, but in the case of LPS, we seem to see a much firmer, a more important role for leukocyte adhesion. And what we don't see in LPS-induced vaso-occlusion is the formation of heterocellular aggregates between neutrophils and platelets. So we know that these heterocellular aggregates play a very important role in some vaso-occlusive processes, but they don't seem to be playing a role in LPS-induced vaso-occlusion, which is a bit different to what we see with interferon alpha-induced vaso-occlusion and human-induced vaso-occlusion. So what we think of these are obviously are preliminary data, but they are leading us to think that possibly we might be able to approach and tailor reverse approaches to vaso-occlusive crisis according to the event that caused that vaso-occlusive crisis in sickle cell disease. We think that in the case of bacterial infection-induced vaso-occlusion, where we see not so much of this rolling of the leukocytes along the blood vessel wall, but we do see a very firm adhesion of these leukocytes, we believe that it might be very important to inhibit integrin activation on the surface of the leukocytes and also diminish endothelial activation. On the other hand, for those events that cause a very significant increase in the formation of heterocellular aggregates, which is what happens when you have hemolysis, and you also have in response to the viral cues being interferon alpha. It may be that antiplatelets or anti-selectin approaches could work very well for this, for reversing or diminishing this kind of vaso-occlusion. So these are preliminary. The mechanisms that we're preparing this for publication at the moment, and at the moment we're looking at the different ways to reduce this vaso-occlusion with drugs, anti-platelet drugs, anti-endothelial drugs, to see whether these drugs have different effects depending on the molecular trigger of this vaso-occlusion at the moment. So we've been seeing that there are a lot of different causes of vaso-occlusion, inflammatory causes of vaso-occlusion in sickle cell disease. And one of the things that we think is important is to understand the sources of inflammation in sickle cell disease, so that understanding these pathways obviously is going to be important for diminishing inflammation and for ameliorating pathophysiology in sickle cell disease. And there are a number of sources of inflammation in sickle cell disease. These are both sterile and non-sterile, and one of the most important sources of sterile inflammation in sickle cell disease, as you all know, is intravascular hemolysis. So when the sickle cells rupture in the vasculature, they're going to release their contents, including free hemoglobin, and this hemoglobin will react very quickly with nitric oxide in the blood vessel, releasing the potent DAMP, which is the heme molecule. So when you have this depletion of nitric oxide in the blood vessel, this will have important consequences. You're going to facilitate vasocclusion, and the fact that you don't have nitric oxide in the blood vessel is going to trigger some inflammatory pathways and activate some cells in the vasculature. The graph on the right shows just some data from an acute intravascular model that we have in the lab. You can see that after inducing hemolysis in the mice, there's a very rapid increase in cell-free hemoglobin in the plasma of these mice in just 15 minutes after the hemolytic event, and also a very important increase in plasma heme in these mice at 15 minutes. However, within about 3 hours, you do see a normalization of both the hemoglobin and the heme levels in these mice when the hemolytic stimulus is acute. And that's because we have scavenging organisms, scavenging systems in our organisms. But we do use this hemolytic model to look at how inflammation occurs in response to hemolysis. So once we have the release of hemoglobin and heme from our red blood cells, they not only cause vasocclusion due to consumption of nitric oxide, we're going to have the generation of reactive oxygen species with oxidative stress being generated, and the liberation of damps from the red cells. So as well as heme and hemoglobin, we're going to have the release of other damps such as ATP and heat shock proteins. And all these damps are going to activate powerful innate immune responses. And we see here in the bar graphs that an acute hemolytic event that we see after using our intravascular hemolysis model, this hemolysis will induce very rapid generation of inflammatory cytokines such as TNF-alpha, interleukin-1 beta, and interleukin-6. This all happens within about an hour of the hemolytic event. In response to this intravascular hemolysis, as well as inducing the generation of these cytokines, we're going to get other inflammatory molecules being generated. Chemokines, growth factors, which are important for angiogenesis, angiogenic processes, as well as acute phase proteins. There is a rapid inflammatory response just to intravascular hemolysis, and we can look at this using in vivo imaging. You see here in vivo imaging using a myeloperoxidase fluorescent probe. This is a mouse, a normal C57 mouse, which hasn't received any kind of inflammatory stimulus. There you can see some localized inflammation in this mouse. However, when the mouse receives a hemolytic stimulus, within just 15 minutes, you see a generalized and very accentuated inflammation in this mouse that occurs very quickly. This systemic inflammation occurs within just 15 minutes of inducing the hemolysis and continues for at least 60 minutes in these mice. And this hemolysis is actually this inflammation that we see after a hemolytic event is very similar to the inflammation that we see in a mouse with sickle cell disease. So here on the right, you see a mouse with sickle cell disease that hasn't received any kind of inflammatory stimulus. And these mice demonstrate continuous inflammatory processes that are very similar to the inflammation that we see in these mice after inducing hemolysis. Obviously, this inflammation that occurs as a result of hemolysis seems to be a major driver of cellular activation and cellular adhesion, and it is a very important therapeutic target for intervention in sickle cell disease and other hemolytic diseases. So at the same time that intravascular hemolysis will cause inflammation and the activation of cells, what we see is that intravascular hemolysis by itself causes leukocyte recruitment. So again, we're using intravital microscopy here to look at a venule in a normal C57 mouse, and here we induced intravascular hemolysis, and again, within just 15 minutes, we see the rolling and the adhesion of leukocytes to the vascular wall. So this is a very accentuated leukocyte recruitment that occurs just in response to hemolysis. The only inflammatory stimulus here is hemolysis itself, and it occurs very rapidly. And at the same time, all of these this vascular inflammation that occurs in response to hemolysis is going to have major physiological consequences. So we see that our hemolytic events causes vascular inflammation with leukocyte recruitment in the vasculature. We can look at the effect of this hemolysis by looking at laser Doppler flowmetry again and laser spectral contrast imaging in real time. And we see that just hemolysis by itself reduces blood flow velocity in the skin of mice and will reduce the perfusion of the skin. And hemolysis by itself has physiological consequences. It decreases blood flow and blood transfusion in the skin, and therefore seems to have an effect on reducing tissue perfusion and potentially causing some ischemic events in tissues as in general, just as a result of hemolysis. So the sources of sterile inflammation are various in sickle cell disease. We've seen how intravascular hemolysis leads to the release of DAMPs and the active oxygen species, but there are also other sterile inflammatory processes that contribute to inflammation in sickle cell disease. One of these being leukocytosis. So, as you know, most patients with sickle cell disease demonstrate very significantly increased leukocyte numbers, and this is probably due to the inflammatory processes themselves and also by shifts due to shifts in hematopoiesis. And these leukocytes appear to be far more activated in the circulation of patients with sickle cell disease, and they release their own sets of DAMPs, such as S100A8 and HMGB1, and also leukocytes, when they're activated, they're a very important source of cytokines such as TNF-alpha and gluconate. And then we have ischemia reperfusion injury, which is contributing to sterile inflammation in sickle cell disease. The vaso-occlusive process itself is inflammatory, and this is because vaso-occlusion will cause a blockage of blood flow, but eventually we're going to have a sudden return of the blood flow to this blood vessel, and therefore this is a kind of ischemic reperfusion injury occurring when you have blockage of the blood flow and the return of the blood flow to the blood vessel. When the blood flow is restored, this can cause oxidative stress in the vasculature, and this is going to end up further increasing activation of the cells in the vasculature and the release of inflammatory molecules and cytokines, and the release of potent DAMPs, all contributing to sterile inflammation that seems to be an important problem driving the pathophysiology of sickle cell disease. So, sterile inflammation due to endogenous processes is important in sickle cell disease, but there are non-sterile inflammatory processes that are contributing to this inflammation in sickle cell disease as well. I spent a long time thinking that it was all down to non-steroid inflammation, but it has become very clear in recent years that there are non-steroid inflammation processes going on. We know that patients with sickle cell disease have intestinal complications. They have an imbalance in microbiota in the gut, particularly, and they also have an increased intestinal permeability. And this all leads to the leakage of microbial-derived components or PAMPs into the bloodstream of patients. So this is going to contribute significantly to inflammation in patients. So once these bacterial components enter the circulation due to gut dysbiosis and due to the increased intestinal permeability, they're going to trigger powerful inflammatory processes again via those innate immune responses. And this is going to amplify vaso-occlusive processes, and we will also contribute to organ damage in patients. So this mechanism was highlighted, one of the first works that highlighted this was by Paul Connect's group, and they linked the microbial environment to the systemic pathology of sickle cell disease. So I think this was an important finding. A lot of people working on how intestinal permeability and gut dysbiosis contribute to sickle cell disease pathophysiology. So we've been looking at these mechanisms in our lab using the sickle cell mice again. We've been using our latest spectral contrast imaging to look at how the intestinal permeability may be altering blood perfusion in intestines of these mice. We can see here the mesenteric blood perfusion of a mouse that doesn't have sickle cell disease. It has a very, very good perfusion of one of the mesenteric loops here in the intestines. However, when you look at the intestine of a mouse with sickle cell disease, you can see that the perfusion in a mesenteric loop of this mouse is extremely reduced. It's much less red, and we have an impaired perfusion in the intestinal region of this mouse. We can see this in a graph here. This is a mouse that doesn't have sickle cell disease. A mouse with sickle cell disease that receives with water administration, they have a very impaired blood perfusion in the mesentery. However, if you give hydroxyurea to mice for 6 weeks, you can actually restore this blood perfusion in the intestine, and you do see an improvement in intestinal permeability. So, summarizing these sources of non-sterile inflammation or exogenous inflammation due to exogenous causes, we saw obviously that dysbiosis and increased intestinal permeability allow damp to leak into the circulation. And we also have a contribution to non-sterile inflammation from infection. And that's patients with sickle cell disease have an increased infection risk due to a compromised immune system. And they particularly have this is particularly due to the lack of a functional spleen, and we know that bacterial and viral infections are very dangerous in these patients and will contribute to the flooding of PAMPs into the bloodstream of patients, which will amplify inflammatory processes and these vaso-occlusive processes in patients. So just quickly covering some of the disease-modifying therapies that we might be able to use specifically for countering inflammation in sickle cell disease. Obviously, we have in use hydroxyurea, most commonly in sickle cell disease as a therapy for these patients. We all know, obviously, that hydroxyurea works by elevating fetal hemoglobin, but hydroxyurea, in fact, has very important and significant anti-inflammatory effects. So we can look at hydroxyurea not only has long-term effects when it's given over time, but it does have acute effects that have an immediate, cause an immediate response in the organism. So hydroxyurea, at least in mice with sickle cell disease, it reduces the production of inflammatory molecules. Hydroxyurea, when it's given in one single dose, can reduce inflammatory processes in the vasculature and reduce leukocyte recruitment. Hydroxyurea reduces angiogenic processes. We haven't looked much at angiogenesis here, but angiogenesis is increased due to inflammation in sickle cell disease, and hydroxyurea does seem to reduce intestinal permeability, at least in mice with sickle cell disease. And most of these effects, they're in addition to being as a consequence of reducing hemolysis by increasing hemoglobin, fetal hemoglobin, some of these effects seem to be mediated by the donation of nitric oxide from hydroxyurea itself, with important anti-inflammatory effects. And of course, we have L-glutamine supplementation, which is also improved for therapy for sickle cell disease, and L-glutamine acts as an important antioxidant. There are approaches that are in development at the moment for sickle cell disease, and that will have effects on inflammation in the organism. We and others have been looking at the effects of pro and prebiotics in mice with sickle cell disease. We have seen that the use of both pre and probiotics in preliminary experiments indicates an improvement in gut health and local tissue perfusion. And in addition to this, we're going to probably see more immunotherapies coming onto the market for sickle cell disease. An important use of an immunotherapy would be for blocking the cytokine activity. There are any number of cytokines, inflammatory cytokines, that could be blocked in sickle cell disease. One of these is interleukin-1 beta. So interleukin-1 beta has a very potent effect on endothelial activation and also affects leukocyte activation as well. So we saw in our previous study that I showed that when you give interleukin-1 beta immunotherapy, or you block interleukin-1 beta in sickle cell disease, you reduce inflammatory processes, you reduce vaso-occlusive processes, you reduce liver organ damage, and we see a very important effect on iron accumulation. Canakinumab has been previously used in clinical trials in humans. So canakinumab is an interleukin-1 beta immunotherapy. In the clinical trial that was published, there was no alteration in pain reporting in these patients, but importantly, there was no amelioration in inflammatory parameters in these patients. So it's possible that we need to find a way to use these kinds of immunotherapies better, thinking about reducing organ damage and not just about reducing vaso-occlusion. And one of the ways to do this might be to inhibit or block the effects of interleukin-1 beta. And then there are a number of approaches to reducing inflammation in sickle cell disease, but one important approach would be to inhibit those innate immune responses that we see are activated by DAMPs and PAMPs in sickle cell disease. One way to reduce innate immune responses is with hemopexin. So plasma-derived hemopexin is being trialed in clinical trials for sickle cell disease at the moment, and that, of course, will neutralize the pre-heme, which is an important DAMP in sickle cell disease. And also, another approach is to reduce inflammatory signaling, and one way of doing this may be to inhibit components of the inflammasome. So in the inflammasome is a protein complex that processes immature interleukin-1 beta into its mature and active form. And we recently published data showing that inhibition of caspase-1 reduces the physiological effects of intravascular hemolysis. It improves blood flow and blood perfusion in the tissue when you inhibit caspase-1, and also the inhibition of caspase-1 does inhibit the vaso-occlusive processes in mice with sickle cell disease. So just finalizing, inflammation plays a huge role in the pathophysiology of sickle cell disease, and as we saw before, it makes a very important contribution to many of the major complications of the disease. These complications include vascular complications, which involve the dysregulation of angiogenesis. This dysregulation is due to inflammatory molecule production, and certainly has a very important role in proliferative retinopathy that we see in patients, the impairment of the healing of leg ulcers and pulmonary hypertension. Inflammation is also a major contributing factor to acute chest syndrome and to stroke, and we know that it affects the bone. So inflammation will increase the stress erythropoiesis in the blood vessel and contributes to osteonecrosis. And finally, as we saw, inflammation is key to triggering vaso-occlusive processes and therefore to causing acute pain in patients, and eventually has a role in the development of chronic pain in patients. And finally, we know that inflammation has this very important role in the progression of organ damage in patients, and we really need to be thinking about reducing inflammation to stop this organ damage in patients with sickle cell disease. So concluding, we know that inflammation drives sickle cell disease vaso-occlusive process. We know that inflammation in sickle cell disease has various sources. They're both sterile and non-sterile, so endogenous and exogenous. And inflammation really does have this important participation in organ damage. So if we reduce the inflammation, this appears to be critical for mitigating organ damage. at least in mice with sickle cell disease, and reducing inflammatory processes appears to be important for reducing iron accumulation and therefore for reducing oxidative stress in organs, at least in mice with sickle cell disease. Inflammation is at the core of many of the acute and chronic complications of sickle cell disease, and the investigation of anti-cytokine immunotherapies is warranted. And clinical trials for new drugs and therapies in general for sickle cell disease should be monitoring inflammatory markers in patients. So at the beginning of the talk, I asked why we study inflammation, and basically we're studying inflammation because we're trying to break the cycle of inflammatory molecule generation in sickle cell disease and the amplification of all this pain, and we need to try and protect organs in patients in the long term by reducing this inflammation. So we see that inflammation is key to the pathophysiology of the disease, and targeting these inflammatory pathways has been identified and is being worked on by numerous groups with a view to developing more disease-modifying treatments that can be used in combination together. So I just want to thank all the people that work in our vascular inflammation lab in the Hemocentro, Brazil, the Hemoglobin and Hepatic Clinic, there are a number of people that contributed to this work, including Erica Gothard, Pamela Brito, Flavia Leonardo, and Lucas. There are other people that have been postdocs in our lab before that contributed to the work, and I want to thank all of our contributors. And this is just a photo of the capybara that wander around our campus in the University of Campinas. They're important integrants of our university. So thank you very much. I'm happy to take any questions now.
Thank you. That was fantastic. I'm a big proponent of the concept that if we can decrease inflammation, we can decrease the significant complications that we see in sickle cell disease. We have Dr. Pollux, yes, plural, have questions or comments in the chat. Dr. Jennifer Pollux says, interesting work. We've looked at endothelin and endothelin antagonists in sickle cell nephropathy and found that endothelial-derived endothelin mediates increased Th17 and nephropathy. Would you suggest looking at monocytes and IL-1 beta as well?
Oh yeah, definitely. Yeah, monocytes are really important due to their migration to the inflammatory tissues. They're also stocking iron in the tissues. So and interleukin-1 beta does seem to be playing a role in this cellular inflammation in the kidney, definitely. So it's a good question.
So one of the
one
of the areas that I'm personally interested in and curious of your thoughts is, one of our biggest problems, of course, is the issue of defining what a vaso-occlusive crisis is or isn't, or the lack of ability to use a decent endpoint in any of our clinical trials. And so I've put forth that many people have already identified that various inflammatory and hemolytic markers predict bad outcomes from acute pain events, and that perhaps we should divide these events into sort of inflammatory and non-inflammatory events as a way of future treating them, right, with anti-inflammatory agents, and propose that perhaps some of the simple measures might actually be useful if you know a person's baseline, something like just a neutrophil count or a CRP. But I wondered what else you would recommend in that sort of panel assessment.
I'm very interested in interleukin-1 beta. The only thing is that I have this feeling that all of the inflammatory molecules are increased during a vaso-occlusive process. So it's very difficult to pinpoint which one is going to be the marker of when an inflammatory process occurs. But I think we really need to be working on this at the moment and deciding if we need to have a profile of inflammatory markers that we need to be using to predict when a crisis is going to happen, and those people that are more at risk of certain kinds of organ damage, for example.
Yeah, thank you. Hi, as a follow-up to Julie's comment and question, my name is El Nassar. I'm here also at UAB. The last slide you mentioned, of course, that clinical trials and drug therapy should monitor, the inflammatory markers in patients. And talking about that profile, as we maybe come up eventually with an algorithm starting from the broad ones and then narrowing it down, what would the ones you would propose for these inflammatory panels that we could just accumulate more and more information, IL, IL beta, what TNF, which are the ones that you would say for these drugs that because eventually the pharmaceutical companies are going to catalog and maybe get some of them clear certified before it trickles down into the clinical practice.
Mm-hmm. So we've been looking at the inflammatory molecules that are increased when we use those different inflammatory triggers for inducing vasocclusion, and we've been using those physiological events as well, such as hypoxia and cold and things like that. So we always see that TNF alpha goes up. We always see that interleukin-1 beta goes up. Interleukin-6 seems to be an important marker, and even interleukin-10, which is an anti-inflammatory molecule, goes up as soon as you induce vasocclusion. Then it goes down a bit later on usually. So there's a whole profile, but there are usually these key triggering inflammatory molecules that seem to go up very quickly after inducing the vasocclusive processes. So there are hundreds, but my go-tos would be TNF alpha, interleukin-6, interleukin-1 beta. Start with, but we need to be working on this, and there may be others that are just as important.
There's another question in the chat. Do you ever see cell-free DNA in the blood of mice with sickle cell disease in the Towns model or in humans? And if so, does it initiate inflammatory signaling?
So I haven't looked at this, but certainly there must be cell-free DNA circulating due to the net release from neutrophils due to cellular destruction and this is going to be an important dam. So I think this is something that we should be looking at as well. I haven't looked at it, but I would like to.
And there is another question about statins. So there was some work done in a couple of different areas looking at statins, trying to understand if they may reduce some of this inflammatory stimulus. Have you looked at that in any of your assays?
Yeah, we published an article years ago about the use of statins, and it does reduce inflammation. We remember what we did exactly now, but this would be a really interesting approach because these statins have those own off-target anti-inflammatory effects, and they could be quite interesting. Actually, it would be interesting to know. There aren't many patients that take statins, so it's a bit difficult to study what happens in those patients that do take them. But I do think there would be an interesting approach that we need to go back and think about again.
I had a question. Nick, this is a wonderful talk. It's so good to hear from you. Coming back to the combined anti-inflammatory therapies, you did show the effect of both P-selectin blockade and IL-1 blockade on improving the blood flow in your mouse models.
Mm-hmm.
Both have been tried individually in sickle cell disease. Maybe we should try a combination of both. What do you think?
So this is, I think, in fact, Julie might have been in one of those meetings. I've had this stems from a study from Novartis, and their question was, can we use anti-P-selectin and anti-interleukin-1 beta together? Would this have a better effect? The problem is when we combined the two antibodies in mice with sickle cell disease, we saw the improvement in vasocclusive processes was actually better. There was a better reduction in vasocclusion, but we saw more organ injury, and we don't know why that is. I mean, you start inhibiting so many things. It might be that we facilitate the migration of the monocytes to go to the tissues, and this, we don't know why that is, but we did see that it actually, the idea was that it was going to be better, but it wasn't. So, and that's in sickle cell mice, of course, it's not in patients, but, it is a warning to be careful about how many different things we should be using together. So.
Well, I just want to thank everybody. Thank you so much for this talk. It was really fantastic. And I really look forward to talking further. And in the meantime, everyone, thank you again. And we will see you all soon, next month, and otherwise, Dr. Conran, look forward to talking more in person. Thank you.
Great
Thank
job.
you.
Thank you
Thanks
so
for the
much.
invitation. Thank you.
Thank you.
Nice to see everyone.